Good afternoon, ladies and gentlemen. I'm happy to be here. I'm happy to share our clinical experiences on use of Nava, invasive and non-invasive Nava, and the research we have started using the information we get from EDI signal. Especially I want to give you the arguments why we started using Nava 5 years ago in Turku University Hospital in Finland. We now have experience of 150 patients, mostly preterm infants on invasive Nava, and 100 patients on non-invasive Nava. And at this time point, with the lack of randomized controlled studies with the long-term outcomes, I think it's still justified to tell about clinical experiences, and I hope it is of help for you. The main goal in our treatment is to protect the brain of the preterm infants and to ensure the optimal later developmental outcomes for our preterm infants. And it was from this perspective we also took the strategy of using Nava in use in our unit. We know that environment matters when we have a preterm infant with a developing immature brain, and modifying our care strategies can make a big difference in the outcomes of preterm infants. In our unit, we could reduce the rate of CP in very low birth weight infants from 10% to 2%, and at the same time we could reach in their cognitive development the normative levels. And if we think what can we do to get there are many things, and in neonatal care, in intensive care phase, we have many known risk factors for later development. Some examples shown in this slide, and those which are underlined, they are related to ventilation of preterm infants. We know that with oxygenation and ventilation, we are balancing between under and over treatment. And when we think of pain, we should avoid both pain and pain medications. We should avoid toxic medications, and we should protect the sleep and protect the infants from stress. And you can see that all of these might be targeted with the Nava treatment. But one of the steps to provide more gentle treatment for our preterm infants was taken 2003 in our hospital when we started using early nasal CPAP at the delivery room. This is a 24-weeker at 1 minute of age getting her nasal prongs. And by using this strategy, we could decrease the amount of intubations, and we could decrease the number of days on ventilator for those who needed ventilation, babies below 28 weeks of gestation, from median 1 month to median 1 week. And with these strategies, we have shown that we have decreased the amount of pain exposure to painful procedures and pain medications. We have avoiding mechanical ventilation. We decrease the risk for accidental hyperventilation, which is deleterious for the brain. And we decrease the rate of infections. This is the sepsis rates in our unit. And we can better protect the sleep of our babies. So along the lines of gentle treatment strategies, it was quite logical for us to take the next step in 2009 and start using Nava for those babies who needed invasive ventilation. This is a 25-weeker baby girl who was intubated at 50 minutes of age, got surfactant, and she started on Nava immediately after intubation. And she's my example patient here in this presentation. Her name is Ella. She's a B twin. And here in this picture, she's 4 days old on her mother kangaroo. And here is her first chest X-ray, which is consistent with RDS. And here you can see how she regulated her PCO2 levels as these patients do. Despite of very small gestational weeks, they are capable in regulating their ventilation nicely. Now I show some panels, and I don't know how familiar you are with these panels, but maybe we now focus on the lowest graph here. So this is a trend curve, 24-hour trends for this patient. This is Ella's first day of life. And here is the spontaneous respiratory rate. And you can see that she had a period about 3 hours when she didn't have that good own respiratory drive. And for the rest of the day, she was breathing well on her own. And when we scroll down the panels in this on this ventilator, we find here a panel which shows the percent time the babies on backup ventilation per each minute. And here we can see like a mirror image of this curve. So during these 3 hours when she didn't have a good respiratory drive, she was on backup ventilation for most of the time, but the rest of the day she mostly had very low percentages on backup ventilation. And here we can see the running curves, and if we again look the lowest one, I can't see it very well from here. I hope you see it from there. Can you? No. So here is the lowest curve is the electric activity of diaphragm, and it's identical to the pressure curve, where you can see that the diaphragm is dictating the pressure, the frequency, and the strength of each breath. And here the conversion is 1.0, so per every microvolt the baby gets 1 water centimeter pressure. Here you also see that the breathing pattern is typical for preterm infants. She has this beautiful periodic breathing pattern, and by looking at these curves we learn a lot about the way our babies are breathing. I want to show also some other babies just to convince you that there is no lower limit. 23-weekers do well on Nava. They can control their breathing. Here is the spontaneous respiratory rate, and here you can see the percent time on backup. You can see that in 2 occasions during this 24-hour period, this 23-weeker, 10-day-old baby boy had more substantial proportion of backup ventilation, but the rest of the day, most of the time, he was breathing or regulating the ventilator from his own drive. What happens when the baby is not breathing, when the respiratory effort fades away, then the backup breaths kick in after the period of apnea we have determined. And in very small, very vulnerable babies, we use short apnea time down to 2 seconds. So here they are. They were twins, Ella and Akseli, at 41 days of age. At this point, they are on high-flow nasal cannula, on kangaroo care, which is known to have many benefits for the babies and their growth and development. But the mechanisms are not so well known. So we decided to examine the mechanisms of kangaroo care using the information from the electric activity of diaphragm and the heart rate we get from Nava ventilator. So we analyzed EDI signal of 17 infants when they were on prone and supine on incubator and on kangaroo, and then prone and supine on incubator. And with this study, which is in press now, we could show that kangaroo care is safe for preterm infants to their cardiorespiratory stability, and the minimum value of the signal between the breaths, the mean value of those minimum values was lowest during prone position and kangaroo care, which tells us that the diaphragm relaxes better when the babies are on prone position or on kangaroo care, which might be one of the mechanisms saving energy and improving the growth in babies who get kangaroo care. Another study question we made and wanted to examine was how caffeine affects neural breathing in preterm infants. And in this study, we analyzed the EDI signal of 15 preterm infants prior and after caffeine loading dose. And we could show that apnea defined as flat EDI signal for 5 seconds or more decreased significantly. The highest value of this signal per breath increased, so the strength of inspiration increased, respiratory rate increased when we took away the apnea periods, and EDI time product taking into account the strength of the breath, inspiration, the length of inspiration, and respiratory rate increased significantly. So using this information, which is reliable and detailed, we could show that caffeine increases neural breathing effort. What we have also written is this kind of practical guideline, and there is the address where you can find it for beginners to use Nava, and I have no time to explain how to use Nava in this presentation, but I just want to tell you that it's very simple, and what you need to observe is what is the highest value for this EDI signal per breath, and according to that value you need to dial up or down the Nava level, how much you support the breathing. And you need to observe the lowest level of EDI signal between the breaths, which tells if the diaphragm relaxes between the breaths, and if the diaphragm does not relax, you need to increase the PEEP. And in preterm infants, very important is to adjust the apnea time because of their variable respiratory effort. And here again is an example where this baby is breathing regularly. I can't see anything, but I hope you do. And when the baby stops breathing, the backup ventilation kicks in after a short 2-second apnea time in this baby. And if you have a more stable, older preterm infant, you can use longer apnea time to prioritize Nava ventilation. And again, here is our example baby, Ella. You can see that in this curve, which tells about the percent time on backup, there are very low numbers. So this baby has a very good own respiratory drive. It should be a routine to check these trends several times a day, because you get new important information of the condition of the baby. Here is another baby who has had stable breathing during daytime, and at nighttime you can start seeing increasing time on backup, and then you should start thinking, what's wrong? Why is this baby now needing more support? There are very few pitfalls, but the most common I have seen is that when you start to use Nava, you take the most complicated patient in your unit and you start to learn using Nava, I think you should start with the healthiest ones who have intact physiology, surgical patients maybe, and newborn preterm babies. But there's no lower limit in gestational age. It works well with babies from 23 weeks of gestation. But why should we go through this effort to try it? There are several studies showing that the peak inspiratory pressures drop down when you switch to Nava, which has better synchrony. Like here, this baby was on SIMV at 18 peak pressure, and after switching to Nava, you can see how the peak pressures fluctuate from breath to breath, but the level was between 9 and 13, and this we see day after day. Here you can see how, maybe, I hope you see, the baby is having very, very nice, easy breathing, and then the baby takes a big breath, sigh breath, and recruits the lungs, and after that the baby is doing again well with very easy breathing. So having lower peak pressures has a potential for lung protection, but really the main argument for us was the potential for brain protection, and now I show you 3 mechanisms which we think might protect the brain of preterm infants on Nava. And the first of them is that there is no iatrogenic hyperventilation, which is deleterious for the brain. The babies control their breathing. They are not hyperventilating. To avoid hyperventilation, we used to have permissive hypercapnia strategy, but high CO2 levels are not good either. So now we are used to, we see normal CO2 levels, and they are around 5 kilopascals in these babies. And this is also shown in a paper by Dr. Stein. And the second mechanism is this decreased need for brain toxic medications. And many medications which may not be that dangerous later in life, they can be very dangerous during the brain development which the preterm infants have. In the only randomized controlled trial I know, including neonates in using Nava, was just published by Merja Kallio, and she could show in her paper that in PICU patients, in non-surgical PICU patients, there was statistically significantly less need for sedation in those babies who were randomized to Nava group. And we have noticed that we need less postnatal dexamethasone, which we know is toxic for the brain. We all know, and we all try to avoid postnatal dexamethasone in preterm infants, but sometimes we are stuck and the baby is too unstable and we need to use it. And we used to be in that situation at about 1 month of age in preterm infants with BPD. They became very unstable. We gave dexamethasone to extubate them, and we used in about 1/5 of the infants dexamethasone. But when we started to use Nava, we have noticed that those patients are comfortable on ventilator. We can wait them to grow on ventilator without dexamethasone, extubate them maybe after 2 months of ventilator care. So we have come down from 20 to 10% in our dexamethasone use in this vulnerable patient population. This is year 2011, where we had 2 patients who got dexamethasone. One was 23 weeker and the other one was 24 weeker. And in 2012, that was 12, and in 13, it was again 2 patients, 24 and 25 weekers each. This was very, very nice to notice. It was a surprise for us to see this kind of new trend. And the third is the third mechanism protecting the brain is decreasing stress and improving sleep in these babies. And that we see in our everyday work very easily. And I think this strategy is easier to implement in units which are used to observe infant behavior, and they they appreciate the well-being of the baby. Parents see it, and if your unit culture is open to listen to the parents' preferences, then I think it's easier to adopt this type of strategy, which improves the quality of life of the baby on ventilator in the NICU. I think it would be easy to show in research too, but there are not really very easy ways to measure sleep reliably in preterm infants. Polysomnography studies are complicated to do. So I have 4 minutes maybe time, so I tell you about NIF-Nava, that in our strategy we have used NIF-Nava as a weaning step. So we extubate the babies on Nava with their EDI catheter to NIF-Nava. We keep them on the same ventilator. We use the same catheter, and we get the same information after extubation. And if the baby is doing well, the babies are then moved to CPAP, and then when they are doing well on CPAP, they are moved to high-flow nasal cannula. And we get the same information. We know how to adjust PEEP when the baby is on NIF-Nava from the EDI signal. And we get good, reliable information of apnea, which is something we value a lot. And we have heard already that the interface might be a problem, and there are different options in NIF-Nava for interfaces. The problem with Nava is the cost, and it needs to be balanced with your budget and with your other needs, of course. If we think who might be prioritized for Nava, if you have to prioritize, we can look by gestational age who need ventilation and who need long ventilation. And here you can see from an international network that up to 27 weeks, all preterm infants need invasive ventilation. This is our spot, so 50% of babies at this gestational age group are intubated. And if you look at the times they are intubated, these are the 5 Finnish university hospitals. From 26 weeks on, the median time on ventilator is a week. But at these weeks, 23 to 25, it's common to have very long durations on ventilator. So I think if anybody and if any patient group needs a gentle ventilation mode, it is this vulnerable population, preterm infants who have their brains developing, and I think we need to take into consideration the long-term effects of the quality of care in this population especially. Thank you.